Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your host for today, Ms. Megan Rossiter, Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Rossiter.
Welcome to today's on-call webinar titled Shifting Care from Hospital to Home, a two-part webinar series where we'll be looking at shifting models of care to more appropriate patient-centered care for chronic diseases, with a focus, of course, on CFHI's inspired approaches to COPD Quality Improvement Collaborative. I'm Megan Rossiter, Improvement Lead here at CFHI, and I'm pleased to be your co-host today. I'm joined by my co-host and Senior Director, Jen Verma, who helped shape and lead the Inspired Collaborative. We're also pleased to have more than 100 registrants for this session and two-part series, and I'm glad that all of you could join us live today for part one. So as I introduce our guest speakers, I'd ask that you please take a moment, I see some of you already doing that, to introduce yourselves in the chat box on your screen at the bottom right, as well to let us know how many people are attending from your location by completing the poll that you'll see on the center of your screen when it pops up. So joining Jen and I today virtually, we have Corey Paul, or Coral Paul. She is the manager of Advanced Practice Home Living Program in the Edmonton Zone at Alberta Health Services. Corey was also the team lead with the Alberta Health Services Inspired Collaborative team. We're also joined today by Melanie Potvin, Director of Medicine Services, as well as Louis Spanjevic, who's a clinical nurse specialist in geriatric medicine, both from Joseph Brant Hospital and leads of the Inspired Initiative at that particular site. We also have our producers, Sheena Powell and Kelly Ripley, operating behind the scenes in Ottawa, as well as our interns with the collaborations program here at CFHI, Catherine Giroux, joining in the room. So welcome to all of you. We are pleased to provide simultaneous interpretation for all of our on-call webinars. This may result in a few quick pauses in the dialogue today, and we also invite you to participate in our chat box today in either official language of your choice. So before we dive into today's webinar, we'd like to get a sense of who's joining us. Please take a moment to answer the poll that you'll see on your screen to indicate your role. If there is more than one person attending from your location, please select the option that is most appropriate for each of you. Let's talk about some of our objectives for this series. So we're thrilled that we're able to host a two-part series that focuses on sharing some of our learnings and results as they relate to appropriate care for chronic disease. There are three key objectives we've highlighted for this two-part series, which includes discussing, firstly, the importance of shifting care from hospital to home and ensuring that care is delivered in the right place at the right time. We want to look at how home and community-based approaches to COPD care can improve efficiency, coordination, and patient and family-centeredness. And we also want to look at lessons and insights from the Inspire Collaborative and CFHI's plans for further spread and scale. More particularly today, we're going to hone in on a few key areas for discussion that relate directly to approaches for shifting care from hospital to home. First, we'll look at some of the impressive results that have come out of CFHI's Inspired Approaches to COPD Collaborative. We'll also have the opportunity to hear directly from two of the teams that participated in this collaborative and hear some of their strategies for success in delivering patient-centered COPD care. We'll also share some strategies for improving efficiency, coordination, and patient and family-centeredness for patients living with COPD and their families. Currently today, our system is facing increasing constraints due to an influx in inappropriate hospitalizations. It's clear that people are receiving the wrong care in the wrong place, which is harming our healthcare system and failing to meet the needs of patients and their families. In work done by Claire Liddy on chronic diseases, it is estimated that Canada spends around $80 billion. That is, $80 billion is spent each year, causing increased use of emergency departments, extended hospital stays, reduced quality of life, and increased mortality rates. And in work done by the creators of the chronic care model at McCall Institute, where Dr. Edward Wagner works, it was reported that current care is not meeting the needs of patients and families and is straining the system. They reported that overcoming these deficiencies will require nothing less than a transformation of healthcare from a system that is essentially reactive, responding mainly when a person is sick, to one that is proactive and focused on keeping a person as healthy as possible. So why are we focusing in on COPD? Although less than 5% of Canadians live with chronic obstructive pulmonary disease, COPD is the #1 reason for hospitalizations in Canada. It accounts for the largest number of return visits to emergency departments. COPD also generates the highest volume of hospital readmissions. Many patients with advanced COPD resort to emergency department care to manage escalation of symptoms or acute exacerbations, which is costly to the health system and patients' health. Here at CFHI, we work with multidisciplinary teams to test, implement, and scale best practices. It all starts with creating the winning conditions for improvement, helping teams to assess, design, implement, and evaluate a proven innovation. The Inspired Approaches to COPD Care Collaborative was made possible through support and funding from CFHI and Boehringer Canada. CFHI supported through the 12-month collaborative a total of 19 teams, which means at least one in each of the 10 provinces, 4 in Western Canada, 7 in Ontario, 4 from Quebec, and 4 in Atlantic Canada. Over the 12 months from October 2014 to 2015, CFHI delivered and supported more than 25 team webinars, an in-person workshop with bringing all 19 teams together, and 4 regional roundtables to discuss sustainability of this work. We also provided funding and improvement tools, one-on-one team coaching with experts in the field, and cross-team learning. The Inspired model that we drew on exemplifies what we're talking about today, that is the shift of appropriate care from hospital to home. As you see on your screen, there are a number of core interventions that Inspired entails, making it a comprehensive model for COPD care. This includes optimization of medications and action plan prescription, as per the Canadian Thoracic Society guidelines, care that addresses continuity across hospital home-to-home transitions, individualized, coordinated, and proactive care that includes in-home things like COPD-related self-management education, psychosocial and spiritual support, as well as opportunity for advanced care planning. It also includes phone access to team support during working hours, monthly phone follow-up for 3 months after scheduled home visits, liaison and partnership building with community and allied healthcare support services, as well as monitoring and evaluation for quality assurance purposes. So what does all this mean? I'd like to now hand it over to Jen Verma, who will take us through a more in-depth look at some of these results and outcomes from CFHI's Inspired Collaborative overall. Jen?
Thanks, Megan. Really appreciate it. And thanks, everybody, for joining. If you missed who had signed up for our call, Catherine in live time here calculated who was joining the call. So there was about a quarter of you that were administrators, an even split between folks joining the line from allied health, consultants, nurses, you work specifically in quality improvement or research, and then there were fewer who were physicians, but really nice mix of folks on the call today. Thank you so much. So we wanted to give you, as Megan said, some quick highlights from some of our learnings from the Inspired Collaborative. So I'll share just the preliminary findings, but know that there's going to be more information like this to come. So when it comes to readmissions, because of course a big part of what we were trying to do with Inspired is really recognizing that home is where the health is. So if we can help to ensure that people don't need to stay in hospital as long, that they can get the care that they need at home, that they have that warm handoff and discharge post-hospital admission, that's really our goal here. So readmissions are, of course, an important part of that. It's not the whole story, but it's part of it. So when we did this calculation, there were 6 teams that were far enough along to be able to demonstrate that the Inspired program that they had customized in their area could reduce unplanned hospital visits for patients. So we could see that for the 146 patients across 6 of the Inspired team sites, there was a notable reduction in hospitalization. So before the patients were enrolled in the program, this group of 146 patients had a combined total of 180 hospitalizations in the 3-month period before they started this program. In the 3 months after, the number of hospitalizations dropped to 33. And we do need to be careful about conclusions we draw from this data, as there's differences across sites, and I think Corey's going to talk about that in particular. So careful around how we pool this data. But the sharp decrease does suggest that the Inspired interventions are working well to keep people out of hospital. we're continuing to gather information from teams to get a better insight as to what's happening 6 and 12 months, given that most teams have passed those points in time now. Otherwise, we're really pleased to say that over 1,000 patients have been enrolled in Inspired-like programs across the country to date, over nearly 1,500 if you include the original Innovator site in Halifax. And then overall, when we were looking at hospitalizations, 13 of the 19 teams had reported reduced hospitalizations throughout the one-year collaborative, and 7 out of 17 reported reduced emergency department visits, and some also reported reduced length of stay. Earlier this year, we did a return on investment analysis working with a company called Risk Analytica to project the potential savings or really contained costs if we were to scale the original Inspired Halifax model to everybody who stood to benefit. So although greater than 800,000 Canadians live with COPD, we know that an estimated 14,000 with advanced COPD would need to receive the Inspired program to benefit. If they were to receive all of those elements that Megan spoke of earlier, we could avoid 68,500 emergency department visits, some 44,000 hospitalizations, 400,000 bed days, and overall, that would yield a savings of upwards of $688 million over 5 years, which means that for every dollar you invest in this program, you could contain 21 in hospital-based costs. What's nice about this work that Risk Analytica did with us is that there's a provincial report. So every single province, we didn't have territorial data, and we know that the prevalence of COPD is not as great in the territories. However, you could certainly use some of the same data and information to compile similar return on investment reports for the territories. So I'd encourage you to look at that on the CFHI website. In terms of our work with the 19 teams that were part of this Pan-Canadian collaborative that was supported by CFHI in partnership with Beringer Ingelheim Canada Limited, we also received some in-kind contribution from Vital Air Canada as well. So we had worked with teams not only to be able to look at efficiency gains, that's important, but we wanted to also be able to look at the appropriateness and effectiveness of particular interventions. Importantly, we also wanted to look at patient and family-centered care components. So for example, the original Inspired program in Halifax had developed a hopes and expectations interview guide, and many of the teams used that guide or an iteration of their own patient experience or satisfaction work or other data sources like the Long Information Needs questionnaire to be able to get at patient and family-centered care metrics. We also used versions of the care transitions measure, which is a great measure of patient self-efficacy over the hospital-to-home transition. There's a 3-point and a 15-point version of this particular scale. So we encourage teams to use these particular metrics. So we're continuing to work with teams to share the results from their work, and today we're going to hear from a couple of teams in particular. A quick word on actually the performance measurement capacity. So because a part of this when we're supporting a collaborative is certainly to support the quality of care outcomes, but also to support teams in gaining capacity to do quality improvement. So what you see here is the results of a 5-point scale that we use to look at measurement capacity of teams at the beginning of the collaborative and at the end. So we've actually marked all, I think, but one of the teams on this scale. And the first point in the scale would be that teams would be exploring measures. 2 would be they've selected practical measures. They're collecting data on measures is 3. They're developing a learning system or 4, so they're using that data to inform changes in day-to-day practice of providers. And then certainly 5, improvement in outcomes. So these are some of the types of things that we look for to understand enhanced capacity. But what you can really see here is that over the 12-month period, that generally speaking, teams did move about 2.7 points actually on this 5-point scale, telling us that they did not only gain skills and competencies around COPD and chronic disease care management and all of that evidence-based medicine components, but that they also gained skills in quality improvement. Similarly, we saw on a 10-point scale, and I don't have that to show to you today, but we saw that teams gained skills in other quality improvement domains. So it was a really nice way to see that while you're gaining capacity to do quality improvement, it can also benefit you as you're trying to drive quality of care improvements, of course. So it's sort of like the improvement before the improvement, if you will. So lots of other results we'll share. Megan and I will share several more from this collaborative at our next webinar. But for now, I'd really like to turn it over to our first speaker. So we're going to start out west. Corey Paul is with Alberta Health Services, as Megan mentioned, but today I think she's calling in from BC. And she's going to be the first to present on their experience from hospital to home for COPD patients in the Edmonton zone. So Corey, over to you.
Thank you very much. Can everyone hear me? And I think they said at the point it was transitioned it would be there. So I'm going to be speaking about the AHS-inspired COPD initiative, which was driven out of the Edmonton Zone Home Living Program. As a refresher, and for those of you who may not have heard previously, the AHS-inspired COPD initiative was based on the premise that individuals in the community with advanced COPD prefer to remain in their own homes for care and support, so long as staff and resources are readily available to assist. In 2014, some individuals in Edmonton's Zone Home Living Program were receiving excellent care for their advanced COPD, but there was no standardized, integrated, or collaborative model of care for this complex and vulnerable population. In addition, approaches to client education varied. There was no clearly defined referral pathway, and the EMR was not designed to assist in client identification through diagnosis. So most certainly our work was cut out for us. We believe that throughout the 2.5 years in working with CFHI that we've been entrusted with legacies of what it means to live with an advanced level of COPD by clients and caregivers, and these voices will continue to influence care pathways in the community and through our future work. When you speak about sustainability, I think you have to look at your ability to sustain, and then also what are the abilities that you have within your organization and your teams. Long before there were discussions on spread, scale, and sustainability, which we call our 3S work, we were working to embed the ICI approach into standards of care for all clients with advanced respiratory conditions, COPD being one of those. We actually continued to work with all of these individuals alongside the ICI cohort. The work has required a commitment to sustain what we've learned and gained and what we've heard from partners, and it's engendered new insights and abilities in the way in which care is organized and provided for these complex populations. In our original cohort, there were 50 individuals enrolled. Since the completion of the formal phase of our work, more than 200 individuals have been enrolled in the community in our Inspired Care pathway. We're also at the present time engaging others in scale, spread, and sustainability discussions and an exploration of our model across the continuing care program streams. We believe COPD is just one complex respiratory condition. The new community care pathway will address individuals with all complex respiratory conditions, including those individuals with neurodegenerative illnesses, lung cancer, pulmonary fibrosis, etc. And in our group of 200 that we've recruited into this initiative, we even have children now benefiting from this work. The ICI learning will impact future discussions with community partners as optimal care across Alberta Health Services care continuum is explored. And ICI will form the foundation of the way in which chronic disease management will occur within the Edmonton Zone continuing programs. So we really believe that the ICI is just the start of a transformation of the way in which we will address clients with chronic, complex conditions in the community. And I challenge all of us today to say, are we talking hospital to home or home to hospital? Because I think it's a reciprocal relationship, and certainly that's the direction we need to be heading in. So while we work to engage in our 3S work, there are a number of components that will be important to consider, knowing that we're in a zero growth budget. And so we have no new resources, no new staff, and it's going to be a revisioning of what we have already to work with. So we will be challenged to work within existing resources, but we're totally committed to doing this. We will be revisioning models of care in the community. We'll be exploring the full scope of practice for staff and our continuing care programs. We'll anchor innovation to our case management framework that is well established and essential in the community. We'll grow with committed community stakeholders and partner with early adopters of change. We're going to base this on population health initiatives as well, and we'll need to utilize metrics and then disseminate our learnings as we go. This is just a diagram of our Strength Through Connections look at the case management framework. On the bottom you have the principles of case management and then the support that we believe surrounds the person who is the focus of our care. In our ICI work, we learned that 92% of our ICI cohort was homebound. In addition to that, 64% of the population had no informal care in the home. We know that moving forward, we will need to optimize client care and support in the community, and that this type of innovation for these highly complex and vulnerable populations must be revisioned. When we looked at family physician involvement in the cohort, we did a review of 50 of the client records. 46 out of 50 had a family physician who was named on the record, and yet only 6 of these family physicians were able to visit in the home. And the clients were so breathless with an MRC of 4 or 5 that they were unable to leave their homes for care, thereby necessitating their use of 911, emergency departments, and acute care for care and services. We believe that access to case managers, nurse practitioners, and registered respiratory therapists for homebound populations is a value-added service. This pie chart demonstrates the tremendous impact on the ICI cohort, all of whom were at high risk of transitioning to an alternate level of care. And yet, despite the fact that nearly half of the population has now passed away, more than half have remained in their homes in the community. We know that this is a fragile and very unstable population, and yet we believe that with community-based resources, there are alternatives to ED and acute care that can and must be explored. I'd like to just address what we consider to be a prevention paradox, and those are all of the individuals where care is managed in the community and thereby avoiding emergency department and acute care admissions. But because this work takes place in the community, it appears to be invisible, and we need to get better at measuring the impact. We took 77 clients who had acute exacerbations of COPD managed in the community, and we applied to them a cost method which would look at their EMS transport, an emergency department visit, an inpatient stay, and we did all of this based on our respiratory health strategic clinical network guidelines for care pathways in acute care. Total cost avoidance for 77 of these individuals would have been in excess of $1 million, and yet this cost saving is not really measured against the costs of acute care. We must work to continue evaluating this impact. These clients have more than just a condition of COPD. These are individuals with multi-morbidity presentations. Sorry, there's an ambulance going by the hotel right now. In a review of just 25 of the clients that were in our cohort, more than 52% had 10 to 20 comorbidities that were being managed. In our work going forward, we will incorporate methods to address medical and social complexity within our cohorts. The pillars for our care will be equity and access, evidence-based care, updates to our EMR, transparent community processes and algorithms, standardized education documentation and interventions, collaborative approaches, and communication and continuity. What is the next horizon for the home living program and continuing care? Right now, we're looking at a future partnership between the Edmonton Zone EMS group, the care, treat, and refer teams, and we'll look at how we can utilize these resources to provide 24-hour care for these clients in the community. We're meeting with regional, provincial, and national partners to explore how we can grow our learning trajectory. There's ongoing development of our metrics intelligence, and right now I'm in Vancouver participating in the 2016 Canadian Home Care Summit, and we've done a number of presentations here in Vancouver relating to the work of Inspired and readiness for change impact assessments by CFHI. For the conference here in Vancouver, I've also put together a video that has incorporated client and caregiver quotes, which we'll call their legacies, and that was premiered here in Vancouver. Just a couple of questions I leave you with. Are we comparing apples to apples? In my own zone, we have no standardized ICD-10 codes that we use when we're going through client data to tell us who has had an acute exacerbation of COPD. If that's true for our zone, it's true for the province, and I know when I looked into it further, it's true for our nation. And I believe that as we hope to advance our work, we're going to have to start to address the differences in our ICD-10 codes and how we're tracking our populations, but we need to do this collaboratively. Accessing a diagnosis for COPD is a tremendous challenge for community partners. We had to review 50 out of our 50 client cases by hand and do intensive chart reviews to confirm diagnoses. We know that our consents do not transfer to third parties for pulmonary function tests. Not all clients have a respirologist, and it's difficult obtaining of diagnostics from GPs. So I believe it's worthy of an effort to look at how we can make accessing the confirmed COPD diagnosis easier for everyone. Many opportunities for palliative and end-of-life care. Evidence suggests the majority of Canadians would choose to die in their own home if they had that option. Evidence from the ICI indicates nearly half of the ICI cohort has now passed away, but the majority of these deaths did not occur in the community. And I ask all of us, what are the collective opportunities here? I believe we need to be mindful in our connections. My father used to say that every encounter is a public relations moment, and I challenge everyone on the call today to optimize all such opportunities in advancing care for this complex population. I think intentionality and passion will go far in helping to advance our common purpose. Finally, optimized primary health care in the community offers a world of opportunities for collaboration with other partners, clients, and caregivers while diminishing the gaps and reducing the risks during transitions between various streams of care. Thank you.
Thank you so much, Corey. Wealth of information, and we really appreciate your sharing feedback and results from work you've led in Alberta, especially while you're at the Home Care Conference, sharing it with the rest of the country. We do have an opportunity now to take questions that our audience has, and we'll have more time also after our next presentation. But maybe I'll just mention, as you have time to put in your questions, so use the chat box, if you will, to add any questions that you have. So it's on the bottom of your screen. And if you've not yet, we're encouraging everyone to indicate how many people are attending from your location. So entering a number, including yourself, because we have a sense of how many lines are dialed in, but we don't necessarily know how many people are sharing a space to dial into today's webinar. So while Corey is at the Canadian Home Care Conference, we also have some of our lead faculty, a few respirologists who worked with us to deliver the Inspired Collaborative at the CHEST 2016 event in LA, also sharing information about Inspired. So we're kind of collectively, I think, doing our due diligence to disseminate information about the Inspired Collaborative. I did just also read from CHEST 2016 that there was another newly released report, to my point earlier around home is where the health is, that indicated that one home visit for people living with advanced COPD increased the likelihood of their keeping scheduled appointments with their primary healthcare providers. It also reduced their COPD exacerbations. That was one visit at home. They didn't even get into the detail around the reduced readmissions. So Corey, I wanted to come back to your point around the prevention paradox, and I thought you guys did a really nice job of sum totaling actually how much the preventative end of the spectrum contains potential costs down the line. Can you talk a little bit more around why you set out to sum total that information, and was it because people were seeking it or because you wanted to be able to demonstrate it, that numbers talk? I'm just curious to know, why did you do it, and if you could give us a little bit more information behind it.
True. Okay, it's a good question, Jennifer. And I think part of the issue is that whenever we come to the tables of decision makers and partners, they don't have a real understanding of the work that's done in the community. So in one of our previous webinars, I had shared that just in one zone or one network office in our Edmonton Zone Health Authority, we complete more than 55,000 professional visits in 1 year, and that's not including all the home support workers who are in the homes or other volunteers that we have go in. So there's a tremendous amount of work done in the community that is unseen. We also know that a lot of these clients, because their COPD is so advanced, that without care and intervention, they would be transitioned to the hospital. So we wanted to use the care pathways that they have for acute care, and we wanted to say if this client with advanced COPD had gone into your facility, this would have been the cost to the system. And yet it's a cost avoidance savings, and it's a way to come to the table as more of an equal partner. And I've been at the Canadian Home Care Summit, and one of the things that I've been taken aback by a little bit is that we speak so much about what's done in the community, but we don't measure it very well. And we don't have very good numbers, and I think it's something we have to get better at. If we're believing that these clients need to spend more time in the community and we need to invest the resources there, how do we demonstrate to our partners and decision makers that there's value added to the system by investing in the community?
Well said, Corey. One more follow-up point to that. In that study I mentioned that was just released at CHEST 2016 a couple days ago, where they said that the one home visit led to the reduced COPD exacerbations and the keeping scheduled primary care visits. There was a point made that a big reason why people living with COPD don't necessarily keep their appointments is because they actually think they might be too sick to go to the doctor or to the hospital. Mm-hmm. So I'm just curious, and given that the work that you've been doing is all in the home, are those sorts of metrics on your radar as well?
They are, and in fact, that came out a lot in the, sorry, I had to summarize a lot, but we did pre- and post interviews with clients and caregivers who were a part of this cohort. And the things that they told us was, number one, they're the last person you want sitting in a doctor's office with people coughing and really ill around them, because they're so vulnerable to illness as a result of the spread of microorganisms. They also said that physicians don't often have the time that it requires to go through their specific issue. And it's because if you look at the morbidity presentation, these clients have a whole list of other issues. And so when a person is ill, there's almost a cascade effect. And they said that the family physicians really just did not have the time to deal with them in an office visit, where it's between 5 to 8 minutes, and a portion of that time is walking into the physician's office and then speaking quickly. The other thing is that they felt often judged when they're in an acute care facility or when they're in specialist offices. And this goes back to what we spoke about through client interviews. One of our clients had said COPD is a judgment, it's not just a diagnosis. And so in some ways they choose not to go into some of our facilities, and by the time they need to go in, they are so ill, they're there for a protracted length of time. And part of it is because of that, they believe that they're seen as a social pariah for their smoking behaviors, which were socially accepted and promoted by government agencies in years past. There's another conundrum. Another conundrum for us to work on.
Well, exactly. I know. This is why, Corey, every time I chat with you, I feel like I'm running down another idea we've got to disseminate from this work.
I know.
Thank you so much. I think we'll continue and we'll head to Central Canada now. We're going to hear from two of our colleagues from Joseph Brant Hospital, Melanie Potvin and Lily Spanjevic. And I understand you guys don't have access to the Adobe slides, so we're going to be transitioning your slides for you. But I'm going to turn it over to you now.
Okay, hello everyone. Can you hear me?
We can.
Okay, great. Okay, so my name is Melanie Potvin, and I am currently the Director of Medicine Services here at Joseph Brant, which really spans the continuum of care from accessing care in the emergency department to transitions home, either from acute medicine or complex care. We also have Lily Spanjevic here, who is our clinical nurse specialist, and she specializes in geriatric medicine and has an interest in COPD. So she manages all of our COPD patient programming here at Joseph Brant Hospital. So a little bit about Joseph Brant Hospital. It is a large community hospital in Ontario. We have about 239 beds. Of which we have 72 beds currently earmarked as acute medicine beds. When we started this journey in 2014-15, we were really challenged overall with accessing good quality care for our community. Our community at the time has a very high elderly population, and in fact that continues to grow. And right now we are experiencing actually our average age is 74 that attends our emergency department for acute medicine services. In 2014-15, we actually had very high waits in our emergency department, sometimes lasting as long as 76 hours, and holding 76 patients within a 40-bed emergency department. So we needed to take some significant action in looking at our patient demographics for all of our disease states and look at how we can first and foremost improve care for those specific chronic disease states, but also ensure that we are increasing access to that quality care for our community. We were well positioned to sort of leverage some of the programs that we had with COPD here through Lily Spanjevic, and we had this wonderful opportunity through the CFHI Inspired Collaborative, which we are very thankful for. And that lands us here today, and we feel very privileged to talk about our journey through this Inspired program. So I think I will, at this point, hand it over to Lily to talk a little bit about some of our poster and the program itself. Next slide.
Thank you very much, Melanie, and good afternoon, everyone. So this slide is one of our promotional posters to help describe our process of recruiting patients for the Inspired program, and also a little bit about the actual plan of care for these individuals as they transition from hospital to home. And I really have to say this was a true collaborative effort with our hospital staff and also community partners. We had a half full-time COPD educator who actually helped identify patients through our tracking system in the hospital, and she would be providing the initial education, trying to do some of the teach back, and with myself as well, we'd be providing the in-depth assessment in collaboration with the respirologist, Dr. Kaloran. And once these people have accepted being part of the Inspired program, they would also have access, telephone access to our COPD educator post-discharge, and we would actually do a home visit, first phone call within 2 to 3 days of discharge, and we do the home visit. We would do that within 2 weeks of discharge, and another 2 weeks after that, a phone call follow-up, and then at the 12-week mark, we'd have another home visit. And Vital Air provided in kind the respiratory therapist time, and our COPD educator and a respiratory therapist would share the visits and phone calls. And if we had determined that there was a need for advanced care planning, families, patients coming to terms with end-of-life concerns, we would partner up with our CCAC spiritual care counselor, Dale, who helped us. It's interesting, you know, it surprises me how many people, even though they're in the severe stages of COPD, still haven't addressed end of life, or no one has given that time to really focus on what will happen next and how a lot of these symptoms can be managed with the appropriate care plan. So this is generally how our program worked, and of course our respirologist, Dr. Kaloran, he's been great at even using iPad, some of the tech side support of providing care to our patients who, for many of them, were not able to get out into the community, make these appointments. So we've had to be versatile in our approaches. And we've also used the Living Well of COPD materials from Dr. Jean Bourbeau to help supplement the education. Many people argue we'll provide the education in hospital, but in the hospital people are stressed, they're overwhelmed, they're not 100%, and we found that, no, the main thing is let's go over the medication and we'll address the action plan at home. And with time in their own environment, with some of the stressors that have been relieved, we found this the perfect time to provide the education. So this is something that we've learned as well. On to the next slide.
And so if we review sort of our start to finish journey, we've actually borrowed this slide from our CFHI and that talks about the journey to process improvement. And so really at its inception, we recognized the need to partner and also identified that potentially we didn't have as strong and cohesive partnerships that transition patients into the community most effectively. And so through our journey, what we made sure is that we had some initial engagement with our stakeholders to understand what the opportunities were and what some of the challenges were. Are we all aligned in terms of our mission and values from an organizational perspective? And do we, each of us, have the resources to be able to allocate within our current infrastructure? So we found that early and frequent communication as we designed our model was very important, and the buy-in from stakeholders was extremely important. Particularly if you're working in community hospitals, there are times when innovation can sometimes stagnate. And so when you bring new model or propose new models of care, initially there can be a hesitation to the healthcare providers, whether they be family practice physicians, pulmonary respirologists, CCAC, or other healthcare providers about such a program and what this means and will impact to their practice and plans of care. And so the outreach, specific one-on-one, was very important, in particular with our family practice physicians, to ensure that they understood the program, the value to their patients, and what the process would be moving forward. This, as we found when we moved through the project, was extremely critical to the success of Inspired, that specific engagement. Without that, there would not have been the buy-in, and in fact, in instances where a family physician may not have been able to have that one-on-one engagement, we actually did have some challenges in having the family physician necessarily support with the patient their commitment to managing their disease in this format through the Inspired program. So we used a lean, we went on then to map our current processes and future state through a lean approach, And we tested these processes with a soft launch, which again, when you're working in a community of practice, which may not be familiar or have a lot of experience with innovation and process redesign, it's extremely important that you take this into consideration when you launch, so that when you do a broader, full-scale launch after having fully engaged, that you've worked out all the kinks, so that you've essentially had your proof of concept that then can have further buy-in and spread from all of your stakeholders in the community, which helps to grow the success of the program. As I've stated earlier, we had some significant challenges, which every organization does in terms of flow and access to quality care, particularly within medicine programs. This is one of our initiatives that has certainly helped to support access to care, and in fact, we're very proud to say that through this and other initiatives, we've been recognized in Ontario as one of the highest improved or most improved for the last fiscal year in our wait times for the emergency department overall. And certainly we've gone from a almost 30 to 40% readmission rate for this particular population in recent years, post 14-15, to now we're approaching around an 11% readmission rate with this and other initiatives that we have towards COPD. So the evidence certainly for sustaining a program such as Inspired is there in terms of both, first and foremost, the quality and impact of care to the patients, so the feedback from the patients and being able to describe that to the funders, and that being potentially internal SLT or senior leadership, or the Ministry of Health. It's important that they understand the impact both to quality, patient care experience, but also the financial impact to be able to create sustainability and improve access to care as our population ages. So we were able to establish a business case with results that helped support our continued resource allocation with our COPD educator in the program. Also, the commitment from our senior leadership team to have this in our annual quality improvement plan also gave importance to the overall program and kept it in the forefront of all leaders' minds, including physicians, of the importance of this type of work. So in terms of our sustaining, we're really at, I guess, if you look at the slide, 4.5, we would say, and we're almost headed into the finish line of sustainability. But now we're really at a point where we want to spread, and the Inspired program, in terms of results, was so successful that we were well positioned again to then open up to other innovative ways in which we can support chronic disease management, particularly for the COPD patient. So what we want to do as an organization is to ensure that we're covering in our programming all states of disease, as well as functional and mobility, in consideration of function and mobility and cognition for patients that have a diagnosis of COPD, whether it be early, middle, or late stage disease, so that there's excellent quality throughout the journey of this disease state. So we have organizational widespread now. We are capitalizing on the great success of the Inspired program, again, to build other programs and partner with our community, with our other hospitals within the LHIN. We have additional complementary programs, such as our Wellness House program, that patients are also able to access for self-management. And we're sharing really the concepts and local results with other agencies. So we're also starting to get inquiries from other organizations about how we're improving our care here at Joseph Brant Hospital through our transformational journey, and certainly there is an interest in the inspired approach. So we feel very privileged to be able to talk with hospitals and other care providers about the impact positively that the Inspired program can have for their patient demographic. We're also investigating OTN opportunities and remote medicine as another way in which we can reach our community and promote community health, because again, as our earlier speaker said, and reinforced the concept that community supports and engagement and self-management is the best way in which we are going to have really healthy communities and be able to support our population as it ages, both in Ontario as well as nationwide. So we are also looking at engaging in disseminating our results and our information with all stakeholders across Ontario, the OHA, Lung Association. So we're really trying to spread an awareness of leading practice with COPD, particularly with the Inspired program and other complementary programs that we have here. So we're really excited about the results that we've been able to achieve. I'm going to hand it over to Lily to talk specifically about those results.
So in terms of efficiencies, we've been able to see a 24% reduction in our length of stay, and that has really sustained over the course of at least 2 years now, from 7.5 to 5.7 days. We've seen a reduction of 68% in our ED visits for same cause, 90 days post-enrollment. We've also, post-program discharge, there appears to be an increased incidence of ED visits, which may indicate a need for longer support, either through the Inspired program specifically or improved integration of primary care. We did see a reduction in the readmission rates from 12 to 12% with same cause, and readmission rates of 13% same cause post-enrollment 12 months, pardon me. So the ED visits with same cause were reduced from 49% 90 days pre-program to about 9%, and 90 days post-enrollment 28% per 5 cases post. So we saw 4 out of 59 of these patients readmitted with same cause in 90 days post-program, and 8 of those out of the 59 were readmitted same cause from 90 days to 1 year post. So again, it kind of lends us to see, well, does it need to go on for longer, possibly? The coordination, we've seen that the COPD educator continues to see that all patients with COPD had a visit, and these people were screened for our Inspired or our Integrated Comprehensive Care program, which is another program we're testing out. We've also done weekly team meetings, including our community partners, but we've also seen an improved access and delivery to spirometry testing. So again, it's surprising, many of these individuals labeled with COPD, we saw in early beginnings that they did not have confirmed diagnosis. So with this program, we've been able to do that quite effectively to 81%. Our focus always remains on the patient goals and advanced care planning, and like I said before, there is phone access to the educator. 100% of our patients received, through the result of this program, 100% of patients received appropriate COPD medication. 95% of these individuals had a self-management action plan. Now, not everybody can follow an action plan for some reason or another, often anxiety or maybe some cognitive issues. So we've had to be flexible with that and really work with the pharmacist and the family doctor or respirologist to ensure that this person had a plan that we could support. 72% of these people were referred to rehab. And, we had 8 of the 10 patients who had smoked go into a smoking cessation program with effect. Our measures with LINC, the score improved by 90%, and 84% these individuals improved with a CTM 3 score by the end of the program. So again, the benefits go throughout, not only efficiency, coordination, but patient-centeredness. To date, we have 68 patients who've been enrolled. 59 of these patients completed the program. 7 patients passed away, and we've had 11 people drop out. 2 of them had actually moved away. And 2 patients actually required more home care, so they belonged to the ICC, where they were transferred to the ICC program.
So I think one thing that is important to note in the status update is really the improved experience for both the patient and the family in terms of end-of-life planning, and ensuring that there was a plan, that the family and healthcare providers were aware, and that we were able to really move forward with that plan in a dignified way, either in the community or here at the hospital, depending on the patient's wishes. And again, you'll remember that Lily had spoken earlier about the limited engagement with patients throughout their healthcare history in talking about end-of-life planning. So if we look to the next slide, where do we go from here? We continue to search out opportunities to spread and scale through the LIN. You'll note that we talked about the ICC program, which utilizes a lot of the inspired approaches, but also enhances some additional home care supports, such as PSW or personal support workers. So that's a different stream of patients that that we are able to capture by having 3 different areas of focus in our programming, which I think is very important and something that we want to continue to move forward with. Again, we want to disseminate our findings and our learnings to our stakeholders so that we build the support for the program, that people in the community become aware, and that we have engagement and certainly a willingness to participate. We actually have physicians seeking this program out now, which just demonstrates the value that they are hearing from their patients in the community. So it's just fabulous for us to be able to hear that. And we continue to work with all of our stakeholders, most importantly our families, to make sure that any patient that has been readmitted, that we're certainly reapproaching if they have opted out of one of our inspired streams. So next slide. So shifting care from hospital to home. Again, continue linking with our community partners. Our medication reconciliation is very important and something that I know is on everybody's mind who's undergoing accreditation. The first phone call, again, is extremely important to reduce that anxiety and connect with the patient so you can understand and alleviate or address any concerns that they may have that may have previously brought them back to the emergency department or potentially got them to a state of anxiety and then requiring some additional intervention. Continue to have ready access to educator and specialist. Again, this was very important when we heard the feedback from our patient population in order to make this a successful program. The fact that they had somebody that they could connect to when they felt anxious or had a question, they felt certainly did help to support them from seeking the emergency department to support their condition. And exploring options to incorporate the program into virtual visits and teaching. And again, we talked a little bit about that. So we're at the early phases of that. And again, we already talked about reconnecting with patients who refuse early on but are at high risk. And so I think that comes to the end of our formal presentation. We may have taken a few extra minutes, so we thank you for that indulgence.
Thank you, Melanie and Lily. We really appreciate it. What we're going to do, because we're at the top of the clock, I'm going to do the poll questions for the audience now, just in case they're heading somewhere else. So I want to make sure that you guys see the poll questions that we put up based on today's call. And then at the same time, there was one question that did come in so far into the chat box, Melanie and Lily, and that was actually from Corey. She was curious about the division between MRC 4 and 5 clients in the cohort that you worked with. Are you able to speak to that?
So and we're not sure exactly what she means in terms of defining how many patients were MCR 4 and how many were MCR 5 that attended?
Exactly, yeah.
Yeah. I would say it was almost close to about 78% of these individuals.
Okay. A couple more follow-up questions. This one from Joanne at Alberta Health Services. So she says, first of all, congratulations on your excellent work and outcomes. Were you able to engage any patients, caregivers as advisors and partners in the collaborative? And then she also said, if so, what impact did they have? What challenges did it present to engage them at a planning level? So she's interested in knowing if you worked with patient advisors in your work.
Yeah, we actually did. We talked with patients who had been using the services in the hospital, and to get their perspective on, what did they want to see in terms of their home care that's provided, and what we can do to help, build their self-efficacy and knowledge to manage their conditions. So we did use their input. We also, early on when we did our soft launch, while we were implementing or testing this model out, we really sought out our first few patients to give us input if this process was working for them. So we did make modifications based on the feedback.
Okay, thank you so much. And actually, Corey just put out an offer to you, Joanne, as well, to connect with her directly to address this from the AHS perspective and their work. And I'll make sure that actually Megan and I start our next call in this series to talk about how patients and families were also involved in the collaborative. So when it came to the Pan-Canadian Inspired Collaborative, how we both involved them, but also encouraged teams to involve patients and families as well. One more question here, this one from Patrick Archambault from the CIS Chaudière Appalaches, who's actually a team lead with one of our Acute Care for Elders, or ACE, collaborative teams. So he was interested in knowing who funds the program. So given that there's this partnership across hospital to community, Melanie and Lily, could you speak to that?
So we each provide resources to support the program. So CCAC works through their programming through spiritual care as well as other social work supports that may be required as we move through the 90-day program. In terms of our hospital, we support by investing in a COPD educator that can go out remotely and see the patient. So that is not through the CCAC, that is actually hospital provided. And we've been very fortunate that we have partners in the community from Vital Air that supported with some in-kind respiratory therapy visits specific to do some more supplemental education around managing COPD and oxygen therapies as we move through the 90-day program.
Thank you so much. So I think that concludes our questions. Certainly if you have others, feel free to follow up with us. And like I said, we'll make sure to prioritize the discussion on patient and family engagement in particular at the top of our next call. But I think, Patrick, your point around funding is an important one too. So we'll ask our colleagues joining the next call if they could speak to that as well in terms of the funding arrangement, given that Inspired is a hospital-to-home program. Thanks everybody for joining. We really appreciate it. Do look out for some of our upcoming offerings, which Megan referenced in the chat box, but we've got a call coming up November 7th on using patient stories for learning and for improvement, so very timely. Are you ready for a little extra? That's going to be a call coming up November 15th, and it's profiling a new program, a new offering of the same program that we've had here for years at CFHI, but the Executive Training for Improvement program. It's an opportunity if you wanted to enroll. And then our second call in this series of Shifting Care from Hospital to Home comes up November 24th, and we'll be really pleased to have the team here from the Ottawa Hospital, as well as the CIS de la Montérégie S joining us as well. And then one last point in the chat box, Megan has let you know, and this is exclusive to this audience, that we actually have a new Inspired Resource Hub. It's an online portal where you can find all resources that are Inspired related, including webinars, articles, tools, presentations, and reports. And we're really looking for your feedback, particularly over these next couple of weeks. And we'll profile this a bit more on our subsequent call, but I really want to thank Beringer Ingelheim for making this opportunity available, and Catherine Giroux, who's really been behind the scenes developing that hub with Megan, our colleague Rachel, and others here at CFHI. So thanks very much. Everybody have a great day, and that concludes our call.
This concludes today's call. Thank you for your participation. You may now disconnect.